actually now provide emergency care.
Right.
So it's your case in point, your first aid, say, like what happens right now if I collapse here?
What happens? I know many of us do not know what to do. We'll start screaming here. We do not know what direction to take.
That's the thing. Yeah. So the ideal situation, you're what we'd call a bystander. So I've collapsed. Yeah. So you're supposed to be able to, check on me, have a number you call.
Right.
To get help. That's an ambulance. Or if you're near a facility, or if your organization has ambulances on standby, get me to an emergency department.
Right.
But case in point in Kenya, we don't do that. So I'll collapse, you'll scream.
Yes. I'll probably collapse alone,
Yeah. Actually, the question I should pose, do you have an ambulance number?
I wanted to ask you that. I mean, how many organizations would have ambulances? How many ambulance numbers do we have around? How quick are they to respond?
Ideally, in emergency medical care, we have what we call the golden hour.
Okay.
So the golden hour is from your case. Now I've collapsed. So it's from the time I collapse to the time I get to a facility or I'm stabilized.
Right.
Yeah. So I have to be accorded care within that period. Yeah. In Kenya, yes, we have a lot of ambulances. Majority are private owned. Counties also have ambulance services, but there is no short code, or number that we can call. Well, the 911 and the 112 of Kenya Police works, but they don't have ambulances that, they'd have to look for to source out ambulance services. So we do not have a short code where I've collapsed, so you quickly dial your, like the COVID number, the 719, and get help. We don't have that in Kenya. So one of the things the emergency care policy is looking to do is, have the system where from the bystander knows what to do. So I have collapsed, so you know what to do. So even when you're asking for help, you're telling the dispatcher at the call center, this is what has happened. And the dispatcher then is able to tell you, okay, while we are sending you that ambulance.
Hold it. I want us to do this practically. You'll probably just take us through a chart that you sent.
Okay.
And I was trying to look at it alongside my producer. And for a moment, I felt like I was lost somewhere.
Okay.
And so I really needed someone to get us through. I don't know whether we can have that on air. Madam Producer, do we have it? All right, we might need to have it kindly, so that at least we are able to go through the same. I know you have it.
Yes.
I have it here. So before it's projected on screen, then you can take us through that process, and then later on we'll be looking at it.
So it's from the point where the scene of, it could be, school is back, so it could be in school.
Yeah.
It could be in this office. So what happens when I get injured or you get injured? So the public that we call bystanders should be able to know how to call for help. Because what happens these days or in Kenya is you'll find that, say a road traffic accident, besides you screaming that I've collapsed, meaning there's a delay in care for me, a road traffic accident happens. What do? We are busy taking videos or, helping the victims on their properties, case in point, stealing their phones and everything. We are pulling out people from accidents where should not be the case, because you do not know what type of injury that person has.
So in this case, are you saying that, well, once someone has been involved in an accident, like they're somewhere in the car screaming, help, 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 you're better off leaving them there as opposed to trying to pull them out?
It depends.
Okay.
If the person can get out, yes. But you find cases where, say, for example, you've crashed, or rather the steering wheel has crashed into your chest, or, there's a metal rod going through your body parts. Ideally, no.
Oh,
because the more you pull, you do not know how to handle that victim. So in an ideal situation, when that happens, someone is supposed to call the number, the short code, the emergency number. There's a dispatch center. So from the dispatch center, then the person calling, the trained personnel receiving the calls, in this case mostly paramedics, are able now to walk the person through, this case the bystander through, tell me how the scene is. It's like this, I'm seeing, a metal rod coming through, whatever. So it all, don't touch, I'm sending an ambulance immediately. So the dispatcher then lets the ambulance vehicle know that this has happened, this is the location. Getting the nearest ambulance. It's not an ambulance, say now, be in your office. It's not an ambulance coming from Kisen Point, farthest distance here is Kenyatta. It should be
the closest we have
around here.
Okay.
Yes.
All right. Can we have that up so that we can look at this process? And I'm sure you have it. I have it also. And it is on screen. Kindly take us through that. I would want to imagine that that's what you're trying to explain to us. Okay.
So you'll see the bystander, the person with the phone call.
Okay.
With the phone rather on, explaining to the dispatch center, this is what is happening, this is the area, this is the number of people injured. So the dispatcher then is able to talk to the bystander. Okay, this is how, if it's an accident, manage it this way. These are the things I need to know. How many people, can you tell their ages? Can you tell me where the injuries are? At the same point, the dispatch is talking to the ambulance service. So the ambulance service then knows we are going to X, where we are picking, X number of people with these injuries.
I get the point now.
If it's injuries that can be sorted out at scene, the paramedics are able to do that.
All right.
Yeah. If it means now going to an emergency department, and I'll emphasize emergency department, not just any other, for the lack of a better word, health center. Yeah, it has to be an emergency department, because then the dispatcher will have already alerted the closest emergency department. You'll be expecting X number of people, these are the injuries. So the team then at the emergency department is prepared. So it becomes a seamless, you see the way you watch in the movies, it becomes a seamless process. So then now at the emergency department, there is what we call triage. So it's not, emergency departments are not supposed to be fast come, fast served as we practice. It's then the team.
It depends
there,
on the.
The team there should quickly be able to identify. Yes, this is an emergency. This one can wait for 2 minutes. This is something we need to handle immediately.
So at this point, this is where the ambulance has come, and now you've gone to the next, to the closest facility around. The closest emergency department. Yes, you need to know that. But I would want to imagine that the emergency department will be in a health facility generally.
Some health facilities do not
have. Some health facilities do not have. But there's no way an emergency department stands on its own. It has to be within a health facility.
It has to be within a health facility.
Yes, that's my argument. All right. All right.
So once the emergency, once now they get to, the other thing is the ambulance. The healthcare workers in the ambulance are called paramedics. So paramedics are trained to stabilize you.
So first aid processes, not really first aid.
Yeah. Advanced first aid. They're able to stabilize you until you get to your next point of care. As opposed again to our normal practice. Yes, I have collapsed. Lydia will quickly throw me into a car or ask for Uber.
That's true. That's what happens anyway.
You take me to your closest hospitals here, say MP Shah.
There's MP Shah, there's Aga Khan.
Yes. So I'll end up at the emergency department from a vehicle that has not accorded me care. Yeah. So for us, that's delaying care.
Right.
Yeah? Remember, I have an hour.
So which is best? Wait for an ambulance for like 20 minutes or get the next Uber that is 3 minutes away?
That's our biggest problem in Kenya. Because we do not have the system. Yes, we do not have the system. So sometimes it's easier to get into that Uber quickly to, or whichever nearby car is, quickly to the emergency department. But the ideal situation, and I keep insisting, the ideal situation is you're supposed to be able to call that short code.
Yeah.
I get help, like there's someone at the end of the call, helping you out. Help is sent, in this case, the ambulance. I get to a department, I'm stabilized, I'm either admitted or discharged or referred.
Okay.
Yes.
All right. So in that case, we are done with that particular chart, yeah?
Yes.
And once one gets to the level of the facility. Now, speaking of which, it's really important then we delve deep into understanding now that you mentioned, there's so much that goes into emergency medicine right here in the country. And we all agree that emergency medicine then would be about stabilizing this person who's not well until they are able to, stay afloat to the next facility so that they can have, care bestowed upon them. So which are the emergency care or medicine areas of concern that we have in the country today?
One, we do not have a short code.
Yes, you started by saying that.
Yes.
All right, that's the most unfortunate.
But
what then strides are we making when we speak about, universal health care, making sure that someone is, we all have a health coverage? I'd want to assume that this would probably be the basic and the simplest of things to achieve.
It should be, but it's not. But one of the strides the government has actually made is we now have an emergency care policy,
all right.
2030.
Okay.
This was launched on the 7th of July this year. It looks at, again, some of those improving the system, making sure now, at some point Kenya has a short code for emergencies that everyone knows. We all know about 911, from watching movies, or 119. But what is, if I told you right now, get me help, what would you call? That's one. Two, our ambulance services are a bit fragmented. Yeah, so it's about bringing them together. As much as majority of them are privately owned, it's about bringing them together to now have a pool that you can quickly, access to provide care, and of course strategically positioned.
Yeah.
It's not just having ambulances in a parking lot somewhere and then, waiting for private people to call them. Three is a central dispatch center, one, or two, you can have county dispatch centers. Yeah. Again, here are trained people who know. So Lydia has called, she said it's 1, 2, 3. Some of these emergencies are things that can be sorted out on scene.
On ground, okay.
Yeah. So they do not have to involve, ambulances, or, for example, if I'm choking. Yeah. If I'm choking and you call and the dispatcher is like, okay, you're choking, she's choking, this, do 1, 2, 3. I mean, it's a quick maneuver. Yeah. And you'll have helped me, even without having to wait for the ambulance. So what I'll probably do is just visit a facility, to get checked and make sure everything is okay. The fourth thing is looking at standardization of ambulances. Case in point, KEBS has standards, ambulance standards, but sometimes when you look at the ambulances available, they are literally vans. Yeah, it's looking at the health workforce. Are they trained to handle emergencies at, any setting? Yeah, with the resources that are available. It's again looking at emergency departments. What are the bare minimums? What should be in an emergency? I'm not talking about big fancy equipment. What is the bare minimum required to actually have a functional emergency department? So it's the soft skills, it's the hardware. Yeah, so looking at some of those things. We've been doing some of that with the 47 counties through our Project 47. So we have training programs for healthcare workers. We are looking to help counties standardize their ambulances using the KEBS standards. We are also looking at having, the bare minimum equipment in the EDs through a program we call Adopt an ED. So this looks at, the staff at the ED, are they trained? Are they on rotation? If not, what are some of the issues happening there? And then looking at the equipment. Again, emergencies are very I think there's a reason why they're called emergencies, because
Yeah.
you look at two neighboring counties and the emergencies
They're
are
worlds
very
apart.
different. Yes.
Okay.
Yes. The emergencies are very, very different.
Mhm.
So it's again going to the ground and understanding. So this is County X.
Uh-huh.
These are their needs. This is County Y. These are their needs. And then working with them to improve the services.
Mhm.
Yes.
So there's not a single point where we'd expect some essence of uniformity, because then the interests and the needs of different counties are different?
There is. Uniformity comes in standardization. So what your standard operating procedures? How does your ambulance look like?
Okay.
Yeah. What's the bare minimum? Yeah. And then with time, then depending on the number of cases you're seeing and the type of cases you're seeing, then you can modify it to meet your needs. Yeah.
Looking at this, that is, we're calling the Kenya Emergency Medical Care Policy, presented by the government right now. What is to pick, what is to appreciate in terms of the policies and in terms of what has been incorporated, and what are the guarantees that this then would be achieved? I know the government should be in a better position to answer that, but what gives you the excitement that there could be something that is worth out of this?
First of all, it's the first ever policy, emergency care policy in Kenya.
Right.
So that for me already is an indication that the government is very much interested and invested in emergency care, emergency medical care. The second thing is looking at the objectives. When you look at the objectives of the policy, you will see there's the issue of, making sure the health workforce is trained. It's making sure there are standards and procedures on ground, looking at the frameworks and the policies that will help, the counties. Because one of the things actually counties now will do based on this is they'll develop their own emergency medical care plans. So their it serves as a guideline of, what would be, for the lack of a better word, improvement of what we currently have. Yes.
Implementation is an issue of concern across. And now that we have an implementation framework here, having gone through it, do you suppose then that it is well inculcated and it is well positioned to actually make changes in the emergency aspect? Because then we say it is a crucial stage. And just looking at the fact that we've really struggled with universal healthcare itself, in as much as we agree that we have made strides.
Yes. The framework is good because what we've done, we've actually piloted emergency care plans in 10 counties so far.
Which are?
There's Nyeri, there's Nakuru, Nyeri, Nakuru, Machakos, Makueni, Taita Taveta, West Pokot, Mombasa, Garissa, Turkana, and Kisumu.
Okay.
Yeah. Just working with the teams, with the healthcare teams in those counties, we have actually seen strides. I know of counties that already are, rolling out their plan. Case in point, Kisumu. Turkana, Nyeri, even the budgeting aspect, because one of the other things that helps the counties do is actually now start looking at emergency medical care, the financial part of it, and also the monitoring and evaluation part of it. Data informs how you proceed. Data informs how much, you're spending or how much you project to spend. So with that, they're better off and more organized. So even then when they are looking at improving their systems, they know what they're improving. Yes. As opposed to haphazard, thinking you need an ambulance. Well, in essence, you probably need a vital signs monitor.
Okay. Yeah. Well, I'd want to assume that this falls in one of the key things that I see have been touched here on the medical emergencies and determinants and consequences, and therefore data could be really important, because you realize that the population is growing by the day. And to be honest, on different sectors, we've not been able to take care of the interests of this growth. And therefore, then health is also a huge concern. Sometimes we have lots of issues when we speak of, the aspect of prioritizing, where to prioritize, what not to, and all these things. How do we have it right to make sure that yes, the priorities are well set, way beyond the data aspect?
One of the things is the monitoring and evaluation of the plans. Yeah, but even that, it's looking at how the plan is developed. It's not just 2-3 people sitting in an office and deciding this is what our needs are. It's done through a stakeholder workshop where now all teams are involved, and all teams in this case, I mean the county health management team, GAO, the national government components like the county commissioners, the police commandants, because of road traffic accidents and security. It's looking at the stakeholders in the county. Once the plan is developed, everyone has a responsibility. With a plan, it's easier to say X is doing this and this. Say, for example, any road traffic accident that happens, the police is involved.
Right.
But one of the things that we actually picked up in this is from the scene of accident to the outcome of the stabilization, where I told you after stabilization, the patient is either, admitted, discharged, or referred. We are never able to track that.
Okay.
So an accident has happened. Half of the times, the police do not know which hospital that person has been taken. Because again, someone will just come pick, drop.
Right.
So there's no follow through. How does the facility track the services provided to that victim, where else chances are you do not know the name, you do not know the age. Yeah, there's no next of kin contact because we've been helped to carry our gadgets. Yeah, so help has been provided, but there is no outcome. You cannot monitor the process.
Right.
So that's one of the things that we actually picked up in these forums. The other thing is given a responsibility. So say, for example, the MedSoup is accountable of 1, 2, 3. The county director is accountable for 1, 2, 3. So it's easier to follow up. Whereas before is, emergency. So who is in charge?
Okay.
Yeah. So who is in charge? I'll give you an example. Right now, to get an ambulance from a county, you can even get a call from the governor.
Why do you want that ambulance?
No, I want an ambulance now, from here to there. Who is accountable? Yeah, the governor should not be calling to dispatch ambulances, for the lack of a better word. There has to be someone who is responsible. Yeah. Who is that person? So that person then is fully aware of where all the assets and both hard and soft are at.
Okay.
Yeah.
All right. We all hope to make strides. I'd want to believe. And as we close in 30 seconds or thereabout, then the biggest role of Emergency Medicine Kenya Foundation in all this. I know you have mentioned somehow indirectly, but where do you come in all this?
Where do we come in? It's to ensure there's a system that provides timely, efficient, and affordable emergency care services.
And we are headed there.
We are.
Soon, we are there. We are headed there. Yes, you rightfully put it that as a country, we still have lots and lots of things to actually do so we can make these strides. We are grateful for that. Quite a wake-up call, so to speak, and we all hope that this is not going to remain as a policy, but it is going to be implemented.
It is being implemented.
I hope so.
Yes.
All right. Thank you so much. Unless there's something else you want to add, Emily Nyagaki, we have to close it at that.
Thank you.
All right. Thank you so much, Director of Programs, Emergency Medicine Kenya Foundation. It was good having you as we discuss emergency care. We are making strides, and we cross fingers that, of course, we'll be able to save many lives, just out of emergency medical care. Thank you so much. I look forward to see you again tomorrow. This is where we close Morning Cafe this morning. We wish you a great week ahead, and of course, full of blessings as I see you tomorrow. My name is Linda Alela. Thank you.